Welcome everyone to this practical clinical guide from Professor Mohammadi's teaching archives. Today we will discuss a structured and clinically useful approach to febrile seizures in children. Febrile seizures are common, often frightening for families and usually benign. However, the clinician's responsibility is to recognize the typical pattern, identify the uncommon but important warning signs, and avoid unnecessary investigations or treatments. Our focus will be practical. By the end of this presentation, you should be able to confirm whether the event was truly a seizure, decide whether it was simple or complex, recognize red flags that require escalation, and communicate clearly and reassuringly with parents. Next slide. Let us begin with a typical clinical scenario. An 18-month-old child presents after a fever, followed by a brief, generalized tonic-clonic seizure lasting about 2 minutes. After the event, the child was drowsy for a short period and then recovered. There is no previous seizure history, the child is fully vaccinated, and the physical examination is normal. These details are very important. The child's age, the presence of fever, the generalized nature of the seizure, the short duration, full recovery, and normal examination all guide our next step. At this point, our first objective is not to order tests. Our first objective is to decide whether this presentation fits a simple febrile seizure or whether there are complex features or red flags that require further evaluation. Next slide. Before labeling the event as a febrile seizure, we must first ask, was this truly a seizure? This question is more important than it may seem. Families may describe any shaking episode during fever as a seizure, but not every shaking event is epileptic. Features that support a true seizure include rhythmic tonic-clonic movements, impaired awareness or loss of consciousness, and a postictal phase with sleepiness, confusion, or gradual recovery. At the same time, we should remember common mimics. Rigors may cause shaking during fever, but awareness is usually preserved and there is no true postictal phase. Syncope may cause brief loss of tone and rapid recovery. Reflex anoxic spells can also look dramatic, especially in young children. So, the first step is to reconstruct the event carefully from witness history. A precise history prevents misclassification, unnecessary tests, and unnecessary anxiety. The next question is whether fever was truly present before or around the seizure. In febrile seizures, the temperature is usually 38 degrees Celsius or higher. The fever may be recognized before the event, during the assessment, or shortly afterward. Therefore, we should interpret the timing clinically, not mechanically. However, fever plus seizure does not automatically mean a benign febrile seizure. A child with fever and seizure may also have meningitis, encephalitis, a metabolic disturbance, or another acute neurological problem. This is why the clinical context and physical examination are essential. The clinician must look for signs of central nervous system infection, persistent altered consciousness, focal neurological findings, or other warning signs. In other words, fever supports the diagnosis, but it does not replace clinical judgment. Next slide. Once we have confirmed that this was likely a seizure associated with fever, the next key step is classification. A simple febrile seizure is generalized, lasts less than 15 minutes, occurs only once within 24 hours, and is followed by full recovery with a normal neurological examination. A complex febrile seizure has one or more complex features. These include focal signs, duration longer than 15 minutes, recurrence within 24 hours, persistent neurological deficit, or delayed recovery. This classification is central because it determines the rest of the clinical pathway. Simple febrile seizures are usually benign and do not require routine EEG, MRI, or chronic antiseizure medication. Complex features do not automatically mean a serious disorder, but they do require a more careful assessment and sometimes referral or investigation. Next slide. Now let us focus on red flags. Red flags are the safety net in the evaluation of febrile seizures. They help us identify the child who does not fit the usual benign pattern. Important red flags include age younger than 6 months, neck stiffness, toxic appearance, persistent altered consciousness, focal neurological signs, prolonged seizure lasting more than 15 minutes, developmental abnormalities, or suspicion of meningitis or encephalitis. If any of these red flags are present, the pathway changes. The child should not simply be reassured and discharged without further thought. Instead, the clinician should investigate further, consider urgent referral, and manage according to the suspected underlying cause. The key message is this: a classic simple febrile seizure can often be managed with reassurance, but red flags must override routine reassurance. Next slide. A common question is whether investigations are needed. In an uncomplicated simple febrile seizure, routine EEG is not recommended. Routine brain MRI is also unnecessary. These tests usually do not change management, and they may create confusion through incidental findings or unnecessary concern. Lumbar puncture is not routine either. It should be considered when meningitis or encephalitis is suspected, or in selected high-risk situations, such as incomplete immunization, signs of central nervous system infection, or concerning findings in young infants. The main principle is that investigations should answer a specific clinical question. We investigate the cause of fever when needed, and we investigate red flags when present. We do not investigate simply because the event was frightening. Next slide. Acute management depends on whether the seizure is still ongoing. If the seizure is ongoing, the first priorities are airway, breathing, circulation, and safety. The child should be positioned safely, and glucose should be checked when clinically indicated. If the seizure is prolonged or continues, an appropriate benzodiazepine should be used according to local protocol. Common rescue options include rectal diazepam or buccal or intranasal midazolam, depending on availability and local practice. After the seizure stops, the focus changes. We stabilize the child, observe recovery, assess hydration, and identify the source of fever. For a simple febrile seizure, chronic antiseizure medication is not needed. Finally, parent reassurance is not a minor step. It is one of the most important treatments. A calm explanation can reduce fear, prevent unnecessary future emergency visits, and help families respond appropriately if another event occurs. This slide highlights common clinical errors. One frequent error is over-ordering MRI in a classic simple febrile seizure. Another is requesting an unnecessary EEG. A third is starting long-term anti-seizure medication after a simple febrile seizure. These actions often arise from anxiety rather than clinical necessity. They may increase parental fear, expose the child to unnecessary procedures, and create avoidable confusion. Another common error is over-hospitalization of a child who has fully recovered, has a normal examination, and has no red flags. But we must also remember the opposite error: under-recognizing danger. Missing meningitis, encephalitis, persistent altered consciousness, or focal neurological signs is far more serious. The goal is balanced care. Do enough, but not everything. Clinical judgment means targeted evaluation, not reflexive testing. Next slide. Referral decisions should be matched to the child's risk level. Urgent referral is appropriate when there is suspected meningitis or encephalitis, focal neurological deficit, persistent altered consciousness, prolonged seizure, or an abnormal neurological examination. Non-urgent neurology referral is reasonable for complex febrile seizures, frequent recurrences, developmental concerns, or diagnostic uncertainty. For a child with a simple febrile seizure, normal recovery, no red flags, and a normal examination, follow-up and parent education are usually sufficient. This structured approach helps clinicians avoid two extremes: referring every child unnecessarily, or missing the child who truly needs urgent specialist assessment. Next slide. Parent counseling is a central part of febrile seizure care. Families often experience febrile seizures as terrifying events. The child may turn stiff, shake, become unresponsive, and then sleep afterward. Even when the event is medically benign, the emotional impact on parents can be profound. We should begin by acknowledging that the event was frightening. Then we can give clear and reassuring information. Most febrile seizures are brief and benign. They do not usually cause brain damage, and most children eventually outgrow them. However, reassurance should always be paired with safety net advice. Parents should know to place the child safely on their side, avoid putting anything in the mouth, time the seizure, and seek urgent care if the seizure is prolonged, focal, repeated, or followed by abnormal recovery. Good counseling converts fear into a practical plan. Next slide. Let us close with a simple bedside pathway. First, confirm that the event was truly a seizure. Second, Confirm that fever was present before or around the event. Third, classify the event as simple or complex. Fourth, screen carefully for red flags. Finally, decide whether the child needs investigation, referral, or reassurance with routine follow-up. The main clinical pearls are straightforward. Simple febrile seizures are usually benign. The clinician should focus on dangerous causes rather than routine testing. EEG and MRI are usually unnecessary in uncomplicated simple febrile seizures. Chronic antiseizure medication is not indicated for simple febrile seizures. Parent education and safety netting are essential. Guidelines are helpful, but every child must still be assessed individually. Sound clinical judgment remains the core of safe practice. Next slide. Thank you for your attention. To summarize, febrile seizures are common and usually benign, but they require a careful and structured approach. The clinician should confirm the event, confirm the fever, classify the seizure, search for red flags, and then choose the appropriate pathway. The best care is calm, targeted, and reassuring. We should avoid unnecessary investigations and treatments while remaining alert to the uncommon situations that require urgent action. Most importantly, we should help parents understand what happened, what to do if it happens again, and when to seek urgent help.